Canada's healthcare system is crying out for reform. While most Canadians quite properly cherish the principle that no person should go without care due to inability to pay, it does not follow that new ways of paying for and delivering care are not necessary or desirable. Hi, I'm Brian Lee Crowley, Managing Director of the Macdonald-Laurier Institute. Welcome to the second video in our series on fixing Canada's Medicare system. In our first video, here's what we learned. Despite high and spiraling costs, our healthcare system underperforms compared to most other countries with universal healthcare. Not only do they offer more comprehensive services, but they frequently have shorter waiting times and they spend less. That's the trifecta. Why should Canadians expect or accept anything less? Can we change the system for the better? I believe that change is inevitable. But on the other hand, I've always been surprised by how much effort it takes to make the inevitable happen. In this video, we'll examine the barriers to Medicare reform, both real and imagined. We'll discover that many of the supposed obstacles to change are illusory. Moreover, many of the past measures intended to fix Medicare are in fact dragging it down. Let's look first at the Canada Health Act, whose supposedly rigorous restrictions have for so long been used as an excuse why needed reforms are impossible. Consider the uproar from defenders of the Act when former federal health minister Pierre Pettigrew dared to suggest that provinces might experiment with private delivery.
It turned into a political firestorm that needed to be managed, and the PMO of the day got frightened off, frankly, from having any further attempt to provoke a mature, responsible discussion on the subject, so it was deep-sixed. Stockwell Day was a victim of the same kind of disingenuous play on the issue. When he was leader of the Canadian Alliance, he said a few things about innovations and reforms and all of that, and right away his opponents were seizing on that, proclaiming that he was advocating two-tier medicine.
Yet many of the people who use the Act to shut down all discussion of reform have never taken the time to find out what it actually says. In his book Chronic Condition, Globe and Mail columnist Jeffrey Simpson argued that many needed reforms are quite compatible with the Canada Health Act.
So the Canada Health Act says that the system should be publicly administered. So it doesn't say publicly delivered, it says publicly administered and financed. So the Act is agnostic on whether you and I form, and 3 or 4 other people, a clinic, sell our services to the government, and raise the money to have a clinic. As long as it's paid for by the public sector, and the public sector is administering the rules, they're agnostic on who's delivering.
MLI's analysis has already debunked many of the commonly held myths about the Canada Health Act. And contrary to those widespread opinions, the Canada Health Act is not legally binding on the provinces. It does not dictate how services are provided. It is silent on who may provide them. It takes no stance on doctors working both inside and outside Medicare. It does not discuss whether fees may be charged for non-insured services. And it says nothing about whether services must be delivered by public entities like hospitals and clinics. Poor Pierre Pettigrew was merely speaking the truth. So why hasn't more been done to improve Medicare? The answer may lie in part with the recently expired Canada Health Accord, negotiated with the provinces by the then Prime Minister, Paul Martin. It injected billions of dollars into the system with hefty annual increases. The result was not so much to buy change, as it was claimed at the time, but to enrich the interest groups who enjoy such power in the public system. Former Saskatchewan Finance Minister Janice McKinnon thinks that deeply entrenched status quo is perhaps the greatest barrier to change.
Finance people said putting money into the system actually prevents change, which is true. If you look at what happened in Saskatchewan when the Romano money came, the government, it was still an NDP government, but it was a different one, had said there's 25 rural hospitals that needed to be closed. As soon as the money came from Ottawa, they said, oh, by the way, we're not bothering to close them. Why would you make a tough decision if somebody's going to give you more money to keep the status quo? So we now know, almost 10 years after the money was put in, that it didn't work. The money did not go to change. The money went really, the biggest place where that new money went, some $40 billion, to increase salaries for doctors, nurses, administrators, unions, all the people in the health system got better wages out of it, was the biggest chunk of money, which is not at all what Canadians should expect.
But change is possible. As Janice has written for us at MLI, Saskatchewan, the birthplace of Medicare, has seen impressive results through harnessing private sector provision. Sweden, as you'll see in our next video, made massive changes to its old Canadian-style system, including privatizing the largest hospital in the country, with very positive outcomes. Other countries with universal access healthcare systems, like Canada's, also feel the need for change. Britain's Paul Corrigan was a special advisor to Prime Minister Tony Blair during the years that his government struggled to reform Britain's National Health Service.
At the 2010 election, the principles of the NHS, which is it's free at the point of need with equal opportunity for everybody, were more popular than they were at any stage since its foundation in 1948. So a story about reforming this institution is a story about reforming something that matters enormously to the British people. And understand this is very similar in Canada. The difficulty, therefore, is you're trying to change something which people love, and almost every change creates an anxiety in the public about what you're going to do. One of the reasons this is possible is whilst people actually love the National Health Service as an overall institution, a lot of their day-by-day experiences of it are not as good as they would like it to be.
As you can see, change is not only possible, it is imperative for the good health of every Canadian. And breaking up the old healthcare monopoly may be the key. By allowing competing providers, we can reduce the ability of entrenched interest groups to run our healthcare system in their interests instead of yours.
Part of the problem in health and making those changes is the entrenched interest groups. The unions, the doctors, the nurses. At the end of the day, when we tried in the 90s to reform our health system, those interest groups eventually turn on the government because they realize that they're going to be affected. And when they say, what the government's trying to do here is bad for your health, the public always listens to the doctors and the nurses rather than the government. So it makes it very difficult for governments to actually want to take on those interest groups.
Canada needs a new national discussion that goes beyond the old myths about the Canada Health Act and the notion that more money is the answer to what ails Medicare. In our next video, join us for a look at several examples of places where healthcare is being delivered more effectively and efficiently than in Canada. Thanks for watching.